Welcome to your monthly update with latest findings from the COVIDENCE UK study. My name's Adrian Martineau. I'm the lead investigator based at Queen Mary, University of London. So let me first highlight to you the progress that we've made in terms of recruitment. Our total number of participants is now at just over the 12,000 mark, so we've achieved our initial target and really delighted to have made this landmark achievement. However, over the summer, COVID-19 has continued to cause considerable morbidity and mortality, not just in Britain, but around the world, with latest estimates at over 350,000 cases in the UK, with over 40,000 deaths, and globally 27.6 million cases and nearly 900,000 deaths. Of course, we are all waiting for a COVID-19 vaccine, but I'm afraid to say that that may not be quite around the corner. Our Chief Medical Officer, Chris Whitty, has said that we shouldn't count on having a jab by the winter. Around 1 in 5 of the public are unsure about actually receiving the vaccine if it's available. And there's some evidence to suggest that even if a vaccine does come out, it's less likely to work well in older people who are at the highest risk of COVID-19 than in younger people. So for all of those reasons, the importance of identifying modifiable risk factors for COVID-19 is greater than ever. And of course, that is a major focus of the COVIDENCE UK study. Now, to date, the approach to doing this has been to compare the characteristics of patients with COVID-19 who've been admitted to hospital against the characteristics of the general population. And by comparing those characteristics, one can get a handle on risk factors for disease. So far, the risk factors to emerge you'll all be familiar with: older age, male sex, being overweight, having diabetes, heart disease, high blood pressure, or being of Asian or Black ethnic origin, all seem to be associated with increased risk of severe COVID-19. However, there are some limitations to this approach in identifying risk factors for COVID-19. The first is an issue called contamination, in that some of the general population will also have had COVID-19. Antibody tests, for example, suggesting that as many as 1 in 5 people who become infected with the SARS-CoV-2 virus don't get any symptoms at all. The second point that I want to raise in terms of limitations of this approach is that it can't distinguish the risks of exposure to the virus from those which are associated with susceptibility to the virus infection, and again, a separate set of risk factors that may be associated with how severe COVID-19 is. And just to illustrate those different factors, I just want to show the progression of the disease from someone who's unexposed to SARS-CoV-2 all the way through to somebody with severe COVID-19. So here at the top of the image, you see somebody who's never been exposed to the virus. Then you'll see a group of people who are at high risk for exposure on the tube in London. Some of those will then acquire SARS-CoV-2 infection, although a proportion of them may become may not develop infection. Then of those who become infected, a proportion may remain asymptomatic, but another group will become symptomatic with COVID-19. And of those people who develop symptoms, again, a subset will go on to develop severe COVID-19 that may require hospitalization. And so when we think about risk factors which influence people's risk of hospitalization with COVID-19, these are actually a complex mix of factors that will influence each of the steps which I've outlined. So to illustrate, there'll be a set of risk factors which will influence whether or not somebody's exposed to the virus, another set of risk factors which will influence whether or not they're susceptible to it, a third set of risk factors which will then influence how severely ill they become when they get infected. And to illustrate a few examples, factors such as what job you do, overcrowding at home, how often you use public transport, whether you live in a city or in the country, whether or not you're shielding, all of those factors could influence your risk of getting exposed to SARS-CoV-2 in the first place. Susceptibility factors might include immune suppression or smoking, and then severity factors might include factors such as whether or not you have an underlying condition such as diabetes or high blood pressure, your age, your gender, your ethnic origin, whether or not you're overweight, and perhaps any medications which you're taking. So this is a complex salad, if you like, of different risk factors. And what we've tried to do in the analysis that we've been conducting over the last month or so is to group these into rational sets of risk factors illustrated here. So all of these various risk factors can be broken down into one of these 7 categories: demographic factors such as age and sex, socioeconomic factors such as income, housing, education, factors influencing risk of exposure, underlying health conditions, medications that are taken for those health conditions, diet, and lifestyle. So when we're looking at these various risk factors for COVID-19, we've adopted 2 potential approaches to the analysis. The first is what's called a cross-sectional analysis, and the second is what's called a prospective analysis. And I just want to outline what I mean by that now. So in a cross-sectional analysis, we basically take data that you've given us from your baseline questionnaire. That's a detailed questionnaire which you completed when you enrolled in the study. We've categorized people according to whether or not they're likely to have had COVID-19 based on the symptoms they report. And those who are classified as having probable COVID-19 here are illustrated in red. Those who are classified as not having COVID-19 are illustrated in green. And then within each of those groups, we look to see what proportion of people with and without COVID-19 have a risk factor of interest present. Then we run a statistical analysis and we compare the proportion of people who are risk factor positive in those who are COVID-19 positive versus those who are COVID-19 negative. The strengths of this approach are that it's quick. In other words, we don't have to follow people up over a period of time to see whether or not they develop COVID-19 in the future. But there is a significant limitation, which is something called reverse causality, which can explain associations. And this concept can best be illustrated by the chicken and the egg scenario. So to take one example of a finding I'm about to share with you, we know what we've found actually in the cohort is that COVID-19 susceptibility is associated with taking less frequent exercise. But we don't know whether that can be explained because having had COVID-19 symptoms makes you feel unwell, so you then take less frequent exercise. Or could it be that taking less frequent exercise up front is associated with having a less effective immune response to the virus and makes you more susceptible to COVID-19? A cross-sectional study can't distinguish those 2. A prospective analysis, that is an analysis which looks at data moving forward in time, can make that distinction. So to illustrate, what we do with a prospective analysis is we disregard data from people who've already had COVID-19 at baseline. We just take those who have not yet had it, we categorize them into whether or not they have our risk factor of interest present. We follow them up over time and see what proportion of people with and without the risk factor develop COVID-19 during follow-up. So the analysis compares the proportion affected between risk factor positive versus risk factor negative groups. The big strength of this approach is that it rules out that chicken and egg problem of reverse causality. And that's really why we designed COVIDENCE UK as a prospective cohort study. Of course, the limitation of this approach is that it's slow. We have to allow time to pass in order for some people to get COVID-19 so that we can take this prospective analytic approach. So because that prospective approach is slower and because we need answers quickly, what we have done is used a cross-sectional analysis of the baseline data from your confidence questionnaires to get a quick handle on what potential risk factors might be, with the big caveat that we can't distinguish the chicken and egg question, which comes first, the COVID-19 or the risk factor. Now, in order to find out who's had COVID-19, the gold standard approach, of course, would be to test everybody in the cohort. But that's logistically extremely challenging. So what we have done is collect all your test results, and you can see here that of all the people who completed the baseline questionnaire, around 5% had a test, of whom 3% tested positive, 1% tested negative, and 1% had a test but whose results they didn't know at the time of completing the questionnaire. So instead of using those test results, which are available obviously for only a small proportion of the cohort, what we've done is also collect details of the symptoms that you've reported, and we've used this algorithm or statistical model published by Christina Meni, Tim Spectors and others from the Zoe app to classify people according to their symptoms whether or not they are likely to have had COVID-19. So you'll be familiar with these questions as you've completed baseline and follow-up questionnaires. Have you had any of the following symptoms since the 1st of February 2020? And 34% of participants said yes to at least one of the following symptoms: loss of smell or taste, fever, persistent cough, feeling tired, developing diarrhea, abdominal pain, or loss of appetite. And what we then do is we put those answers into a mathematical equation to calculate the probability of whether or not somebody's had COVID-19. And what we find out is that around about 10%, in fact exactly 10% of people who've signed up to the COVIDENCE UK study can be classified as having had probable COVID-19. And this figure fits pretty well with what one might expect from antibody tests showing seroprevalence of between 5 and 15% in the UK population. And we know that the COVIDENCE UK population is significantly overrepresented in terms of frontline workers. So in general, the participants in COVIDENCE, many of them are at slightly increased risk of COVID-19 compared to the general population. And so we run an analysis now looking at all of these risk factors which I outlined earlier to see whether or not they're associated with the symptom complex that suggests COVID-19. And at this point, I just want to thank Hayley Holt, Mohammed Talahi, Matt Greenig and Saif Shaheen, all from Queen Mary, for many hours of analytic work over the summer to bring you the results that we have today, including classification of over 20,000 medications which you've entered into the COVIDENCE UK questionnaire. So first of all, looking at demographic risk factors, I just want to orientate you in the slide. On the left-hand side is the age in years, going from less than 30 years to age 80 years plus. In the middle column, it displays the percentage of people who've had probable COVID-19. And on the right-hand column, there's a statistic which shows whether or not this age group is at higher or lower risk of having had probable COVID-19. Low risk is indicated by a number less than 1 in the right-hand column. And where the numbers in the brackets don't overlap 1, that's statistically significant. If it's decreased, then the number goes in green. If it's increased, then the number goes in red. A word on the statistical approach that we used for anyone who's interested. We adjusted for what are so-called confounders, 15 of them, to ensure that the analysis is yielding robust results. So what we can see here is that there's a tendency, if you look in the middle column, tendency for the percentage of people infected or who've experienced probable COVID-19 to increase to the highest of 14% in the 40 to 50 age bracket, and then decreasing down to just over 5% among people aged 80 plus. And what we have shown is that the people aged 70 to 80 years old have a significantly lower risk of having had COVID-19 symptoms. So this is an interesting contrast to data from the hospital-based studies that I mentioned earlier in the presentation, which show that age or older age is a significant risk factor for severe COVID-19. What we're showing here is that older age actually appears to be protective against having had symptoms of COVID-19. And that's a pattern that will be seen for several other risk factors I'm going to present today and that I'll be discussing later on in the talk. In terms of looking at the effect of gender on risk of COVID-19, we've shown no effect of whether you're female or male at birth on your risk of COVID-19. And again, that contrasts with the hospital data showing that males are at higher risk of severe COVID-19. When we look at whether or not it's a risk factor for actually getting COVID-19 in the first place, it doesn't seem to be. In terms of ethnicity, we've shown here that around 9.8% of our participants of white British ethnic origin had symptoms of COVID-19 compared to 15.3% of people of Black or Asian minority ethnic origin who were born in the UK, and 11.6% those of Black or Asian minority ethnic origin who were born outside of the UK. In terms of socioeconomic risk factors, when we looked at whether or not people's household income was deemed sufficient for their basic needs, what we showed is that those who didn't answer yes to this question were all at significantly increased risk of having had COVID-19. However, we saw no association when we looked at the type of housing or the educational level that people had attained. When we looked at risk factors for exposure, what we saw was a strong association between being a frontline worker and increased risk of COVID-19, with about a 60% increased risk of symptoms in those people who are doing frontline jobs. However, we saw no difference for people being shielding. We didn't see any difference for those whose households were more overcrowded compared to those whose households were less overcrowded. We saw no influence in the use of face masks or gloves in public transport use, or how often people went to the shops. In terms of underlying health conditions, we asked a question about people's general health. And what we showed here is that people who said their general health was good, fair or poor, as opposed to being excellent or very good, seemed to have an increased risk of having had symptoms. Of course, the chicken and egg situation may operate here. It may be that people had symptoms of COVID-19 and that made them say that their health was less good, or it might be that people started off the study having less good health and that this was associated with increased risk of experiencing symptoms. In terms of being overweight, we showed an increased risk for those who are modestly overweight with a body mass index of 25 to 30, but interestingly not an excess risk in those who are more overweight having a body mass index over 30. Again, this is a contrast to the hospital data showing that higher body mass index, or being more overweight, associates with worse outcomes of COVID-19. Again, in contrast to the hospital data I alluded to earlier, we see no increased risk of having experienced COVID-19 for people with diabetes, those with heart disease, high blood pressure, asthma, chronic bronchitis or emphysema, kidney disease or cancer. In terms of medications, as I've said, we classified over 20,000 of the medications which you entered into the COVIDENCE UK questionnaire, and we classified them into 19 main classes of medication, and these included ACE inhibitors, which are drugs that are commonly used for blood pressure or heart failure, statins, drugs used for treating high cholesterol, proton pump inhibitors like omeprazole, which are used to treat excess stomach acid, inhaled steroids, which are medicines used to treat asthma and chronic obstructive pulmonary disease, painkillers like paracetamol and non-steroidal anti-inflammatory drugs like ibuprofen, the oral contraceptive pill and hormone replacement therapy. And none of these medications was associated with a significantly different risk of having experienced COVID-19 symptoms. Similarly, we saw no association between whether or not people had had a BCG vaccine, that's the TB vaccine, or the MMR vaccine, that's the vaccine for measles, mumps and rubella, and their risk of COVID-19. And both of those vaccines had been potentially suggested as conferring a degree of protection. When we looked at diet, again, we saw no association between how much fruit and vegetables people ate, their fish intake, intake of dairy products or fluid intake on risk of developing COVID-19 symptoms. And we also saw no association when vegetarians were compared with non-vegetarians or vegans were compared with non-vegans. When we looked at lifestyle factors, one of the interesting findings that we saw is that if you took one or more hours of vigorous physical exercise per week, that's enough to raise your heart or breathing rate, that was associated with a decreased risk of probable COVID-19. But again, one can't distinguish the chicken and egg in this scenario. What we did also see was that there was no association between whether or not people smoked, either active or passively, vaping, alcohol consumption, less vigorous exercise such as walking or yoga, or the number of hours of sleep that people had. So to summarise this quite detailed data set, what we've shown is that the risk of having had symptoms among the over 10,000 COVIDENCE UK participants decreased with increasing age. There was no difference between males and females. There was an increased risk among people of Black or Asian minority ethnic origin who were born in the UK. There was an increased risk of having had COVID-19 symptoms in people who had lower income and in those who had jobs on the front line. There was some evidence of a modest increase in those who were moderately overweight, but nothing in those who were more overweight. We saw an association of increased risk with poorer health, but we saw no association according to background, long-standing conditions, medications, diet or smoking. Finally, we saw an association between increased vigorous exercise and decreased risk of having had symptoms. So how do those factors compare then with the risk factors already reported in the literature that have been based on hospital studies? Well, they can be broadly put into three groups. There are those which go in the same direction, such as Black or Asian minority ethnic origin, being overweight or having poorer health. There's a second group which directly contrast with those of the findings from the COVIDENCE UK. So, for example, In COVIDENCE UK, we showed that there's a decreased risk of symptoms with increasing age, whereas hospital-based studies have shown that there's an increasing risk of severe disease with increasing age. I've highlighted the sex difference, with males in hospital-based studies being shown to be more likely to have severe disease, but no difference in our study between males and females in terms of having developed symptoms in the first place. Being a frontline worker doesn't seem to increase severity, but it does increase risk of getting symptoms in the first place. Having diabetes, heart disease or hypertension is associated with worse outcome, but doesn't seem to be associated with getting symptoms. And similarly, smoking has been associated with worse outcomes, but in our study not associated with getting symptoms in the first place. Then there's a third group of factors which haven't really been investigated in hospitalised patients, but we've investigated in the COVIDENCE UK study, looking at income, medications, diet and exercise. So the bottom line from the results so far is that this population-based approach can provide insights into risk factors for milder disease, and that contrasts with the findings from hospital-based studies. And when we take our findings together with findings from the hospital-based studies, this can help us to dissect apart the factors that influence whether or not we're susceptible to COVID-19 versus the factors which influence how severe COVID-19 is. So our study, of course, has some strengths and some limitations. In terms of the strengths, it's a national study with very wide coverage of a representative sample from all over the UK. We've got a big sample size now of over 10,000 participants in this analysis. The study is population-based, and we have very, very detailed information on a whole range of risk factors thanks to your patience in completing our detailed questionnaire. In terms of our limitations, the definition of COVID-19 is not based on testing everybody, it's based on symptoms, and so there will be a degree of misclassification there. And secondly, the cross-sectional design can't rule out the question of whether or not reverse causality might be operating. So the associations that we report here can raise hypotheses, but in order to test them definitively, we're going to have to do longitudinal studies. So let me just talk about that. Longitudinal study, also known as a cohort study, that's the unique thing which COVIDENCE UK is bringing to the table here, the fact that we follow people up over a period of months. And just to remind you about the analytic approach here, we're comparing the proportion of people who get COVID-19 in those with or without a risk factor as we follow them up over time. So that brings me to the end of the presentation, but I do just want to highlight how you can continue to help us to get to the bottom of identifying modifiable risk factors for COVID-19. First of all, do please continue to complete your monthly follow-up questionnaires. We're absolutely delighted that so many of you are doing this. To give you an update on the numbers there, 23,184 out of a possible 24,662 monthly questionnaires have been completed. That's 94%, which is a really fantastic follow-up rate for a cohort study that's been set up so rapidly and is of such scale. So I really want to commend you all for your continued input and thank you for what you've done in giving us these data. Please continue to fill in the monthly questionnaires. Please also continue to spread the word. I'm delighted to say we've hit our initial target of 12,000, but if we can reach 15 or 20,000 participants, it will increase our statistical power to detect effects of risk factors which may only confer a more modest increased risk, but which may still be important on a public health scale. And the third thing that I would urge you to do is if you do develop symptoms in the weeks or months to come, please do make as vigorous an attempt as you can to get a test. I appreciate that this is not straightforward and that testing capacities currently being stretched to its limit. But if you do get symptoms, by which I mean a high temperature, a new continuous cough, or loss or change to your sense of smell or taste, please arrange to get a COVID-19 antigen test as soon as possible. This must be within 5 days of symptom onset, but the sooner you can do it, the more likely it is to be sensitive, and so it's much better. You can get hold of the test either by making an online request by visiting nhs.uk/coronavirus or by calling 119 to arrange for your test. So I'd just like to close by passing on the thanks of the whole COVIDENCE UK team from Queen Mary, King's, London School of Hygiene, Edinburgh, Belfast and Swansea. Thanks to you, the participants, for all of the data that you've shared with us, and please continue to complete the monthly questionnaires, and I'll have another follow-up webinar for you in a month's time with new emerging findings. Goodbye.